Hi, my name is Wei Wang, and I'm going to talk about celecoxib and CYP2C9. Celecoxib, also known as Celebrex, is a non-steroidal anti-inflammatory drug, NSAID. It is commonly used to relieve symptoms of osteoarthritis, rheumatoid arthritis, acute pain, and to reduce the number of colorectal polyps in patients with familial adenomatous polyposis. It has a wide range of side effects. Severe symptoms of overdose include breathing difficulty, coma, gastrointestinal bleeding, etc. Cases of death have been reported. Celecoxib's pharmacological effects are mediated by its inhibition on prostaglandin synthesis. Unlike most other NSAIDs, celecoxib is a selective inhibitor of cyclooxygenase 2. Now I'm going to talk about the role of CYP2C9 in the metabolism of celecoxib. CYP2C9 is a phase 1 drug metabolizing cytochrome P450 isoform. It is responsible for the metabolic clearance of up to 15 to 20% of all drugs undergoing phase 1 metabolism. It is also the major cytochrome P450 isoform that catalyzes the hydroxylation of celecoxib, which leads to its inactivation and clearance from the body. CYP2C9 gene is highly polymorphic. Among the many CYP2C9 variants identified so far, there are two non-synonymous variants that are most studied and best characterized. One is a cytosine to thymine transition that results in an amino acid change from arginine to cysteine at position 144. The other is an adenine to cytosine transversion that changes leucine to isoleucine at position 359. The minor alleles of these two SNPs are also known as CYP2C9 star2 and star3 alleles, respectively. Both of them are relatively common in whites both of them are relatively more common in whites than in Africans and Asians. The arginine to cysteine change at amino acid 144 is non-conservative and is predicted to be damaging by SIFT and polyphen. But leucine to isoleucine change at position 359 is conservative and is predicted to be tolerated by SIFT and benign by polyphen. Both variants have been associated with reduced enzyme activities in vitro and reduced clearance rates for a variety of drugs in human studies. The most notable example is warfarin. There has been direct evidence supporting the role of CYP2C9 in celecoxib pharmacogenetics. For example, both CYP2C9 star2 and star3 alleles have been associated with reduced clearance of celecoxib in some studies, although the evidence is not completely consistent. CYP2C9-3 heterozygotes have shown higher incidences of gastrointestinal bleeding associated with celecoxib intake in two small case control studies. One large randomized clinical trial in 2009 has suggested that CYP2C9-3 genotype may influence the efficacy of celecoxib in preventing colorectal adenomas, but it still needs to be confirmed by other studies. Now I'm going to summarize our current knowledge on the role of CYP2C9 in the pharmacogenomics of celecoxib. The current level of evidence is 2A. This is because of the important role of CYP2C9 as a pharmacogene in general and its important role in celecoxib metabolism. However, current data on the association between CYP2C9 variants and celecoxib pharmacokinetics are still limited and inconsistent. Given the potential severe or even fatal side effects of celecoxib, identifying individuals who are at higher risk of such side effects is critical and will likely be the most important clinical utility of pharmacogenetics for celecoxib. Currently, the FDA recommends but does not require genetic testing of patients from at-risk populations before initiating treatment with celecoxib. Before we can draw firm conclusions about the clinical utility of CYP2C9 genotyping, we still need to confirm the pharmacokinetic associations observed for the two common coding variants. And the rare variants in CYP2C9 need to be studied for us to fully capture the genetic variation that can result in individual differences in response to celecoxib. Here are the references I used in my presentation. Thank you for watching.